Welcome, everyone, and thank you for joining us here at Aquinas College and online. I'm Dr. Jennifer Hess. I'm the chairperson of the biology department here at Aquinas College. It's nice to see you all tonight. The Your Health Lecture Series is a unique educational partnership between Aquinas College and the Michigan State University College of Human Medicine. The goal of the series is to feature physicians and researchers who can speak on a wide variety of topics of interest to the public. The speaker, Dr. Armstrong, met with pre-med students prior to the public lecture. Additionally, Aquinas College pre-med students had the opportunity to take part in a roundtable discussion with MSU College of Human Medicine students. MSU College of Human Medicine and Aquinas College have been collaborating on the Your Health Lecture Series since 2013 as an extension of the Early Assurance Program agreement between our two schools. Now, I would like to welcome Mark Breavy, Director of Community and Government Relations at Michigan State University College of Human Medicine, to introduce our speaker.
Great. Thank you, Dr. Hess, and we do appreciate the partnership between MSU College of Human Medicine and Aquinas College. I would like to note at the conclusion of Dr. Armstrong's presentation, she will answer questions from the audience and those written into the Q&A feature of the Zoom meeting for as long as time allows. With that, I would like to introduce our speaker this evening. Dr. Kelly Armstrong is an assistant professor in the Office of Medical Education Research and Development, AMRAD. She is a physical medicine and rehabilitation specialist and serves as chief of the Moral Learning Society within the Shared Discovery curriculum. She cares for patients with a variety of medical conditions, including musculoskeletal and neurological injuries, chronic pain, and other deficits of function. She has worked with the MSU College of Human Medicine for 4 years as a clinical educator prior to assuming this new role in 2020. Dr. Armstrong received a bachelor's degree in biomedical engineering from Michigan Technological University and a medical degree from Michigan State University College of Human Medicine in 2010. She completed her residency in physical medicine and rehabilitation at the Mayo Clinic in 2014 and went on to do a short research fellowship with the University of Washington in Seattle. She has worked at Mary Free Bed Rehabilitation Hospital in Grand Rapids since 2015. Dr. Armstrong.
Thank you. Let me get all set up here. All right. I'm going to clip this so I don't have to mess with it. Well, thanks everybody for having me. We appreciate you guys coming tonight and for everybody online. I'm going to take you through the world of rehab medicine from a quality of life perspective. So it'll make more sense when we get into it, but we'll talk a little bit about what rehabilitation medicine is. It's a pretty niche field in medicine. It's not probably a specialty that most of you have heard of unless you've had experience in the field. So we're going to talk about that in depth. I'm going to tell you about the types of patients that I work with, give you a little bit of background about the history of why this field started. It's actually pretty interesting and it hasn't been around for that long. We also are a field that adapts to advancing technology. And so that was something that brought me into the field. I'd like to talk about that. And then the other thing that I sort of mentioned in the title is, why does rehab medicine impact quality of life and how does it do it at different time points and stages across the lifespan? And then I'll give you guys who are sitting in the room or people online that are a little bit more local to us and maybe even from far away, an opportunity to learn about how to get involved and learn more about this field because it is something that maybe you haven't seen before. So just a little bit about me. I am a graduate of MSU CHM, so I'm super proud to be here representing our school. I grew up in Lansing, so it was a pretty natural fit for me to go back home and live with my parents for the first 2 years of medical school. I think my mom is listening right now, so hi mom in Lansing. But moved back home after getting my undergrad degree in engineering from Michigan Tech, so another small school way up in the UP. Like Mark said, I did my residency at the Mayo Clinic, and now I hold 2 very distinct roles in this community. So I see patients at Mary Free Bed. I'll tell you a little bit more about them. Actually, that's one of my patients on the screen. That's Emily. I've seen her for a number of years. She's somebody that I hold near and dear to my heart. And I also work as the assistant dean for career advising at CHM. So I'm the dean that gets to help students figure out what kind of doctors they want to be. And then I get to help them figure out how they can get to where they want to go. So that's a really, really fun, very rewarding job. My patient mix at Mary Free Bed looks a lot like sports medicine for the any person. That's what I typically say when people ask me outside of medicine what I do. So I take care of a lot of patients that have back injuries and joint injuries, but a lot more than that too. So we'll talk about what that looks like in just a second. Really, I like to say I'm a functional doctor. I do a functional assessment, but we'll talk about what that means. So where did rehab medicine come from? I like to think about this in terms of where did sort of the study of movement and the study of understanding how movement impacts function come from? So there's a couple of time points or a few different time points across multiple centuries that we can kind of see people started to realize that movement as medicine is something that's helpful to help people move and feel better. So as far back as 2500 BC, people in China utilized movement therapy to relieve pain and promote health. We started to hear about gymnastic exercise to prevent disease in Greece in 500 BC. There's some published works in the 1100s emphasizing exercise, diet, and preventative medicine. So we're starting to see some more just sort of like construct around what movement in medicine actually does to help people. In the 16th century, we started to see trials of things like prosthetic hands and limbs from blacksmiths. They started to make things to help people use limbs better that needed help. And then we started to see the concept of what's called neuromuscular reeducation, which is still something that our physical therapists and occupational therapists use as part of their treatment plans today, back in the 1800s. And it really was the world wars in the 1900s as patients or people came back from war injuries where our field in rehab medicine really took off as a formal type of medicine. So we'll talk a little bit more about that. Excuse me, FDR, for you guys who don't know, hopefully you do, is Franklin Delano Roosevelt. He was a prior president who developed polio and required rehab. That was in 1921. He had enough money to make a rehab facility for himself. And so what he did is at his home, he recruited people to help him get better. That included people like physical therapists, massage therapists, occupational therapists. He had a swimming pool there that he utilized for his rehab. He had people that could make braces for him to help his limbs move better. And that was a way that people that also had polio around that time looked to somebody and said, hey, he did it better than I'm doing it. He has the money to do that. How come I don't get that? And so people in the population started to say, well, we need help after we have things like polio, disabling conditions that make our level of function different. So people started to operationalize that in ways that maybe didn't cost so much. And so some of his experience started to transition therapies to people like pediatric patients with cerebral palsy, patients that couldn't move well for other reasons. They started to get therapies. They started to put braces on kids to help them walk better. And that was really kind of the start of seeing that in the general population because they saw that in the newspapers as FDR got better. The first university where the department of PM&R was established, PM&R is physical medicine and rehab, that was in the 1920s by this guy named Frank Cruzen, who's now known as the father of rehab medicine. So when I was a resident in rehab, everybody said, you got to read the Cruzen textbook. And I was like, okay, I'll read the Cruzen textbook. But no, he really actually started our field. So that was a big deal. He went to Mayo, where I trained, to establish a department of rehab in the 30s. So I didn't realize when I was a resident there, like how historic that site was that I went to train. Sometimes in medicine, you end up in spaces where you're like, wow, there's some really like historic events that have happened here and you don't even know because you just went there because you thought it was a good place to go. But the specialty in itself wasn't actually formally recognized by the American Medical Association until the 1940s. So our specialty has been around for 70, 80 years now. And it was really during World War II when the vets were coming back that formal sort of rehabilitation centers were created. And it was really directed by this guy named Howard Rusk, who worked for the military and worked for people coming back from war that had injuries that required rehab. He went on to found the Rusk Institute of Rehab Medicine, which is one of the top rehab hospitals in the country. It's in New York. Actually, one of my mentees that went through CHM and graduated last year is going there next year as a resident. So it's really cool to see that history kind of play out. So what is a physiatrist? So I'm saying a lot of terms that mean the same thing. Physical medicine and rehab doctor, physiatrist, that's all the same thing. It's just different terms. So these are definitions by our board of PM&R. This is a doctor with training in treating disorders or disability. of muscles, bones, nervous system. But don't other doctors do that too? Like that's kind of confusing, right? Conditions might include things like amputation, arthritis, back and neck pain, brain injuries, concussion, chronic pain, and so on and so on. Could also be doctors who are nerve, muscle, and bone experts, kind of similar to the last statement, and treat injuries or illnesses that affect how you move. I like that one a little bit better. It's a little bit more specific. But other doctors do that, right? So we're still talking about systems that overlap a little bit with other physicians like orthopedic surgeons, like neurologists, people that you kind of can put a system to. So still lacking in terms of a good understanding of what we actually do. So then what do I tell my family members? Hi, Mom. That's something that I had to really work on because they didn't understand. So the broad scope of PM&R is what makes my specialty exciting, but it's really, really confusing. And the confusing part about it is that we don't focus on one organ system. We don't have the bones. We do that. We don't have the nervous system. We also do that. We don't really have cardiology, but we do that too. And it's really the function of all of these things that we're paying attention to. So it's that I'm a function doctor. It doesn't matter what the disability or injury or illness is that a patient has when they walk through the door is. I look and sort of diagnose the patient's situation from a functional perspective and come up with a treatment plan to maximize the goals that they have when they come to see me. So we'll talk about what that means, but the treatment plans really emphasize maximizing that function and improving quality of life. Went the wrong way. So what's special about my specialty? I think, this is very biased, of course, that PM&R is the quality of life specialty. So we aim to maintain and restore optimal function for patients in all the different spheres of life that you think about. So if you have social function issue, emotional, medical, vocational, we're looking at all of those areas of life and all of the goals that a patient brings to you pertaining to those areas to enhance a person's functional prognosis. So I work on teams. One of the biggest reasons that I liked my specialty choice was that when I was growing up and trying to figure out my specialty, I wasn't super comfortable thinking about myself as like a doctor on a pedestal. Like that's how I thought about like a surgeon. Was I comfortable as that doctor? I wasn't. Did I want to be surrounded by people that were really, really good at what they do and we could all work together as a team in the lanes that we were good at to make a good plan for a patient? Yeah, that made me feel a lot more comfortable. So I see myself as the quarterback of that team. I work with patients that need things like physical therapy, occupational therapy, need particular types of nursing, need different types of psychology management, need bracing, need all these different things. And I work to create a plan for them that involves all of those people to put them back together functionally. So what do I actually do, right? Because that's a lot of kind of big thoughts. So common diagnostic tools that I use, I would say that from a history and physical examination, that means when I'm talking to you in the office, if you're my patient, and I'm hearing what you're bringing to me in terms of your concerns and what your goals are, we are really, really good listeners because we really try to put together what those goals mean for you. And my physical exam from a functional perspective is one of the best ones that you can have because I look at how you move and I use my background in engineering to help me understand how that movement is impacted by things like pain and muscle spasm and joint destruction and things like that. We do labs, we send tests like MRIs and x-rays and things like that. We do neurologic testing. I use medications and injections to trial, helping to take pain away to try to help somebody move better. So those are all sort of up for grabs in terms of my toolbox. And a lot of the different things that I prescribe, I've mentioned already, the different types of therapies. I try to relieve pain. I use bracing to help people move better. I use things like Botox, not for wrinkle reduction, not for them, but for muscle spasm reduction in limbs. I use a lot of motivational interviewing and coaching, which I didn't know I was going to have to do so much, but found out that it was actually a really comfortable zone for me to be in. So it was a nice, happy sort of coincidence. And a whole lot of education. So anytime I have students or residents rotating with me, one of the biggest things that I tell them is that you need to provide education so patients understand why you're doing what you're doing to help them achieve the goals so that they're invested in that plan. Otherwise, like how many times have you been to the doctor and they tell you, well, just go do this thing, but you don't understand the why. And then you don't really have the motivation to do that thing. So we spend a ton of time on that. So who are my patients? So these are the areas of rehab medicine that we have extra training programs associated with. So fellowship programs is what I'm talking about. And there is a ton of overlap. So I could see anybody from any of these buckets without having a specific clinical fellowship in these things. That's the cool thing about PM&R or physiatry, is that like my world is very broad and wide open in terms of the types of patients that might come to me. The only one that I don't see a ton of is I don't do a lot of little kid pediatric rehab medicine, because that is really specific, and little kids are not small adults. They're actually children. So the fellowship training that is required for that, I think, is really, really important. Not that it's not for the other things, but that's the area that I tend to stay away from. So just some pictures kind of representing those people. So the top picture on the left might be somebody that has ALS that's still using something like physical therapy to move and feel better despite having weakness in his limbs or difficulty with breathing. The person on the top right might be somebody that's getting a procedure to help with back pain so that they can do their physical therapy better. The person on the bottom, everybody loves adaptive sports. There's a ton of adaptive sports in the Grand Rapids community if you haven't seen it yet. The Mary Fairbaird Y is a really cool place to see that for basketball tournaments and things like that in the summer out in the softball fields. So we work with patients to get them into chairs that work for them to achieve the goal of race or sport. And then the bottom left is maybe a pediatric patient that had an amputation because of cancer. So we work on providing limbs for those patients and helping them move with those limbs so that they have this adaptive device and actually want to use it. So super inspiring to be able to give patients those types of progress towards goals. So for an individual patient, what do we pay attention to? So like, how do I figure out when a patient tells me what their goal is, what it actually means in terms of what I'm going to talk to my team about to help program for them? And so we'd start talking about things in a standardized way. So activities of daily living are just basic self-care tasks that measure a person's functional status at its baseline. So all of those things that you can read on that list are things that you do every single day without thinking about them. But if you have something like a stroke, or you have something that's an impairment just with a limb in terms of like an injury of some sort, you might not be able to do those things as well or as easily without assistance. And so those are things that we think about. The next level up is what I think of for instrumental activities of daily living. So these are like your two-step things, right? So money management doesn't mean that I can't get the money out of my pocket, but can I count it? Can I actually manage it when I'm trying to pay for something? Do I know how much is left? That's a cognitive task, which is, I talk a lot about physical things because that's the space that I live in, but we also focus on cognitive issues as well. So these types of things we think about too. And so we can create treatment plans, or we can create therapies that help them access these things at the same time. So I have a huge list. Of course, I'm not going to read this huge list, but these are all just off the top of my head, things that patients have come to say, I want to do these things better. And that's what I ask people when they come to see me. When I have a first-time patient, which happens multiple times a week, one of the most important questions that I ask is, what do you want to do better? Like, what is it about whatever you're coming in with that's preventing you from doing what you want to do? And that's what I focus on to help create a treatment plan. It's not like my assessment of their situation, it's their assessment of their situation. Like, I don't feel good. I want to pick up my kid better off the ground. Okay, well, what do you have to do that? You have to bend at the hips to get down to the ground. You have to bend your back. You have to be strong enough to do that. You have to have balance to be able to do that. And so I take whatever their goal is and put it into terms that sort of fit with a therapy plan. So kind of looks like personal training sometimes. And I do some of that in the office, which is also pretty fun. Everyone, no matter what their goal is, wants to be more independent. That's why that's at the bottom. So whatever it is, they want to be able to do anything that they want to on their own the best they can. So what is this team that I keep talking about? So sample rehab team. So my treatment plan is going to come from many directions. I'm never going to have a patient where I'm just like, do one thing, because it's usually not that. So I use back pain a lot because that's a lot of the patients that I see have back pain. A lot of patients that I see will say, well, I've had things like injections for pain in my back and they never helped me. And then I'll say, but what else did you do? Because if you just have an injection for pain, but then you don't change the reason why the pain is there, then of course it's going to come back. Like, that sounds like a really good business model for somebody, but not really a great treatment plan for keeping your pain away. And so then we talk about, well, how do you move your body and what's actually underlying the structural problem that is resulting in pain? Can we change that? Can we support the spine better with strength and flexibility? Those things are really important to keep pain away. So even if you get an injection, at least you can do those things to make sure you don't have to have another one. So it's a lot of like assessing the situation and just making sure you're approaching it from all the different directions that actually fully help it instead of just one thing. So I'm going to go into a couple of these different therapies. And the reason is I know you guys are in the undergraduate space and you may have some variable kind of exposure to things like physical therapy, but I want to make sure that you kind of understand what these different types of people do, because these also might be things that you might want to do in addition to medicine. I don't think I fully understood what a PT really did until I worked alongside them. But in a nutshell, doctors of physical therapy, which most of them are at this point, address those injuries of disability that impact a patient's global ability to move. So when I think about how to utilize a physical therapist, I'm really thinking about like that global movement stuff, off the ground, walking, balance, things like that. They use exercise, so that means strength, flexibility training. They use things like modalities, so that means like massage-based therapy, heat, dry needling, stuff like that. They can help out with trialing things like bracing. So if somebody has a foot drop, they can help look and make sure that that brace actually fits them right and make sure that they correct their walking like it should. And sometimes they have their own subspecialties. So they can do additional training in things like musculoskeletal injury. They can do cardiac therapy, neurotherapy that looks more like working with folks that have had neurologic injuries like strokes or spinal cord injuries. Even things like women's health, so pelvic floor therapy lives in the PT world for folks with pelvic pain, and then chronic wound management. So those are all physical therapy subspecialties. Occupational therapy is even more like nebulous to some people because occupational therapy automatically are going to think it's for people that work. That's not really what it's for, although that does apply. So OTs are the folks that help people participate in the things that they want or need to do through the therapeutic use of everyday activities, which might be work, but it also might be like, I like to paint, or I like to write, or I like to feed myself, or I like to brush my own teeth. It's the things that you have to do to take care of yourself or interact with your environment. So they can have their own sort of subspecialties too, including cognitive rehab. So they live in this space where folks maybe have had something like a stroke or a traumatic brain injury where they don't have the thinking that they had before, but that's a trainable deficit for a lot of people. So they challenge people in different ways cognitively to help reconnect some of those processes in the central nervous system. They're the folks that specialize in feeding therapy for kids that have trouble with eating. And they also do things like driving evaluations, home safety evals. They work with assistive technology to help patients that can't talk. And so if you think about, if you've ever seen Stephen Hawking with his eye gaze computer-aided speaking device, an occupational therapist set that up for him. So that's a really cool assistive tech device. And then speech pathologists are relatively self-explanatory, but they also dip into the cognitive sphere. So OTs and speech therapists can do very similar things when it comes to cognitive therapy and communication. Okay. And then we have a whole bunch of other people that we work with. So the recreational therapists are like some of the most fun people that I ever get to work with because they literally get to like go and ask patients what they like to do for fun and then help them do those things. So they're the folks that program our adaptive sports department at Mary Free Bed, and they get folks into prosthetics that help them sprint and bikes that help them race and do all these different things for sport. But then there's also recreational therapy of like, say you like to play guitar, but your hands don't work that well. Well, let's figure out that so that you can have a joyful life. Rehab psychology is also a really great resource that we have. So those are folks that help with counseling related to adapting to disability, which is a really, really important thing for folks that have new onset or even chronic disability. We have the orthotics and prosthetics folks, and those are the people that build things for people to use to walk and use their upper extremities better. I always say that if I didn't go into medicine via the MD route, I probably would have done that because I would have got to work in a workshop and like hit hammers against things a lot, and that would have been really fun for me. But those are really skilled folks that we have that we get to help people walk and move better with too. So being a nerd who was historically an engineer, I really like the technology of rehab. That was one of the reasons that I got into the field, was that I was interested in the prosthetics and I was interested in neuromodulation to help control limbs. That means like putting arrays on brains and then using that to control an external limb. That's so cool to me. It's only in research right now, but it will come. And so new technology keeps us on our toes. Patients also do too. So one thing that happens in rehab is that, you guys know, if you hurt yourself, you're probably going to get better to some degree, right? Like if, and this is true even with central nervous system injuries. For a lot of people, when they have a stroke, we provide a medical intervention or not, and a lot of them get better to some degree. And so we have to keep an eye on that, being rehab doctors, be involved early and sort of create or plan interventions at that early stage to help them get better more efficiently or more completely. And that is a really fun space to be in because people are changing every day. You guys know that broken bones heal on their own. They might not heal in a straight way. They might not heal in a way that's functional, but we can provide therapies that help them do that. And these technology advances that I'm talking about, you guys know that AI is happening at a very rapid pace. Some of the computer-aided technology that's implantable is also changing very rapidly. So that's all in our space because these are all things that are made to help people do things better. So this is some of that kind of fun, nerdy stuff that I like to think about. So assistive technology really like exists in the space of communication aids and eye tracking. We're using virtual reality for folks that are paralyzed, which is a really, really cool way to improve quality of life because they can feel like they're moving even if their bodies aren't. And that's really good for mental health for a lot of folks. There's wearable devices. You don't see these like in public, but these are in research spaces where people with paraplegia don some sort of like external robotic device and can actually walk with it. It started in research in the military space, but I think will come into the general population relatively soon. Cool thing with prosthetics, like I told you about the implantable sensors that you can essentially think and move a limb because of. Those are really, really cool and probably emerging soon as well. In the field of regenerative medicine, so that means like using your own body to help grow new cells is really cool to think about, right? So think about using, the most common thing right now is called platelet-rich plasma, where we take out some of your own plasma, spin it down so that it's just full of platelets and inject it back into an area that's chronically damaged. That tends to stimulate cell growth and helps with things like osteoarthritis. And there's a whole host of other types of substances that are being studied in that realm. And then the sort of line of implantable devices for neuromodulation, either for pain control or for helping people move again, is also like up and coming. So if you think about somebody who's paralyzed from the waist down and you put a sensor up against their spinal cord where that paralysis happens, we can make electrical transmission happen over that injury and help people move again. So those are things during your lifetime, all of them, that you'll probably see as potentials to help with patients. So pretty cool space to be in, especially if you're kind of nerdy. So where do I get to meet my patients? I like to talk about like the settings of patient care because they're not all as intuitive as I'd like them to be. For those of you who haven't been to Mary Free Bed, this is our outpatient clinic. It's like a rainbow everywhere you go at Mary Free Bed. It's a really cool space. Those are glass sculptures that are just hanging over our patients' heads. They're very safe. But they're based on a artist that, if you've heard of Chihuly, they're kind of Chihuly-esque statues. But this is where I get to work the days that I'm actually in clinic. So I see patients with stable problems. I do outpatient procedures. We do diagnostic testing in the outpatient space. I work on outpatient therapy referrals and other types of testing referrals. And I also refer to other physicians. So like if I find that somebody is having difficulty with breathing when they're walking, sometimes I'll engage a cardiologist to make sure that we're not missing a heart issue that would cause that same symptom. So we really work on collaborative teams to make sure that we're looking at patients from all the directions that make sense. The acute care setting, so this is like Blodgett Hospital across the water over there. So how we operate in this space is we do consultative visits for patients who are unstable that need to be in the hospital. So think about somebody who's just been in a car accident or has just had a stroke or just had a spinal injury. And so we do kind of assessments on where they are with their recency of injury in terms of what they can tolerate in terms of moving again. We help with pain control when services asked us for that type of advice. We work with the inpatient therapy teams to help them understand how the injuries impact what type of therapy is appropriate for them. And we coordinate transition of patient care into other spaces like rehab hospitals. This is one of the coolest places that I get to go because when a patient's been in a situation that feels very new and very scary, and there are maybe symptoms that they don't completely understand, the rehab doctor gets to come in and provide hope, which is really cool because a lot of the time they're hearing from the teams that are surrounding them in the acute care hospital, like, you almost died, or you're never going to walk again, or these things that are really scary. And we get to say, well, I've seen somebody have this happen to them before and then do okay. And that feels really cool. And that's the privilege that we get because we don't just stop at that inpatient hospital setting. We see them with some longevity kind of outside of that situation. And so then they might come to an inpatient rehab hospital like Mary Free Bed. So this is a place where it looks like a hospital, it smells like a hospital, not in a bad way. The food is not as good, not very good, just like a hospital. But this is a hospital that's focused on that functional outcome and rehabilitation. So I'm there as the physician to make sure that any medical problem that comes up, like pain or blood pressure issues or diabetes or things like that, are managed safely. And the therapy teams are there to make sure that patients can kind of get back to normal, get back on their feet so that they can get home. This setting, you need to have a person that can tolerate 3 hours of therapy over 5 days a week. So 3 hours a day split up into a bunch of chunks. And that's insurance that drives that, which is kind of unfortunate. Some patients are really, really motivated and want to do more than that. And obviously we try to do that. And some patients can't tolerate that. So if that's actually, I took that part out. But if that's the case, then sometimes they go to a different type of level of care, like a skilled nursing facility or a nursing home, historically is what those are called. So we help those inpatient teams kind of figure out what's appropriate for the patient where they're at while they're in the hospital. Okay, so now we're on the question of quality of life, because that's what this talk is about, right? So how do we improve quality of life? If I haven't convinced you yet, I'm about to. So we use that multidisciplinary approach. We use all of these people to help one person get better by addressing their physical impairments, reducing disability, and enhancing these outcomes. These are outcomes and quality of life that are actually really well studied in the literature. So physical function, psychological well-being, subjective symptoms, that means things like pain, social function, your ability to interact with other humans, and cognitive function. So this is one of my favorite things that PubMed has done over the last bunch of years. And it shows you sort of like the prevalence of research studies when you put in particular search terms over time. And I love this because quality of life in rehab research has really grown. So it's just a fun picture to look at. But then I'm going to give you a whole list of things, right? So how do things like yoga and aerobic exercise have an impact on different types of things, plus quality of life in breast cancer survivors? So a whole bunch of different patient populations. The next one is about cardiac rehab. The next one is about Parkinson's disease. Then there's talking about stroke rehab. Then we're talking about kids with CP. So a lot of different patient populations that this is being studied in. So we're going to look at a couple in particular. So I like this one. This is a big systematic review of physical rehab in the ICU from a few years ago. And so does early rehab in the ICU contribute to improved quality of life? So where does this question come from? So if you're in the ICU, you're super sick, right? You have to be there. And so I'm not sure necessarily what the super sick is. It could be sepsis. It could be you have pneumonia. It could be you have renal failure. It could be heart failure. It could be any of those things. But this was a review of 5,300 participants, 60 clinical trials all together, looking at quality of life outcomes. So the intervention was engaging those therapies while the patient's in the ICU versus not, versus after they've been there, still in the hospital, but not in the ICU. And we know that things like range of motion, resistance training, it just means like using your muscles, transfer training, respiratory muscle training, that means like using your lungs in a functional way. They improve ICU and hospital length of stay, means you get out of the hospital sooner if you get therapy in the ICU. They improve delirium, which means you get your head back on straight much sooner if you get these things in the ICU. And they improve physical function at multiple time points. So that means like they look during ICU stay, at the transition to the regular part of the hospital, at discharge home. Everybody does better at multiple time points in physical function. Did I prove it yet? Okay, we'll go again. So now that there's a ton of research in post-COVID conditions, this is your long COVID patients. Does rehab intervention improve quality of life in the COVID patient population? So this is another one where they looked at 14 trials and they were looking at breathing exercises, again, resistance training and aerobic training. And these trials showed functional exercise capacity improvement, improvement in dyspnea, which is shortness of breath, and quality of life. And the cool fun fact about this group of research studies is that as a result of studies like this and lots of other ones, our specialty became the leader on clinical guidelines for patients who had COVID and long-lasting symptoms after that. So if you look at like, what do you do for patients that have prolonged symptoms after they've had COVID? You go to our board's website and the clinical guidelines for treatment of those patients is there. So that's super cool. Okay. So rehab medicine all across the lifespan. So I've told you a whole bunch of different types of interventions that we can kind of program for patients, no matter what their problem is. And I told you at the beginning that when I explain this to friends and family members that I call myself a function doctor. So I hope that you kind of understand after this that, again, it really doesn't matter what the person comes to me with in terms of why they're not feeling well or why their function is impaired. Their functional goal exists no matter what their diagnosis is. So it might be some little tiny baby whose parents would like her to sit up on her own or take a bottle. It might be a kid with cerebral palsy who has pain from muscle tension and who can't sit in his wheelchair comfortably. It could be a person who wants to rehab a knee injury and get back to running. It could be somebody who wants to use their arm better after a stroke, or somebody who has cancer at the end of life and has nausea, but still wants to be able to go home and move around their house and interact with their family. It doesn't matter because we're sort of there for anybody that has a functional impairment. Okay, so kind of wrapping up, it's really a privilege. Like, I hope that that kind of comes across. I get to meet patients at their hardest times and create that plan to make it easier, which is like such a cool space to be in. Personally, I love watching the way people move. I'm one of those people that sits out on park benches and watches people and makes judgments without saying anything out loud about why they're moving certain ways. So I love using that skill that I learned in my undergraduate degree and applying it to my current job. I think it keeps my brain engaged and it makes me feel proud that I'm able to do that with some efficiency. Like I said, I didn't know that I was going to be such a cheerleader and a motivational interviewer. But I get to do that and I like to do that. So it gives me some of that empathy feedback that I think as a physician over time you need to make sure that your cup always stays full. And I get to see how patients' hard work leads to huge improvements in their quality of life. When my patients do better, I always tell them, you did all the work, because they do. Like, they're the ones that are doing the therapies. I'm just making their plan. But that's really cool to see that happen. And that's really cool to see the smile on their face when they know that that's the case. And being a witness to humans achieving goals is really, really important. And the last point that I make is that it is unbelievably cool to be the type of doctor that other doctors come to with questions. I had an orthopedic surgeon a couple of weeks ago call me and say, you know, Kelly, I am not sure what to do with this person. Could you help me? Because he couldn't figure out why she was in so much pain after having a hip replacement. And I was like, yeah, bring her in. And we created a treatment plan that got her better really quickly within a week. And it's a really cool space to be in to say, okay, if it's not surgical, I can help you. And a lot of the time in that situation, it's not. Okay, so how can you explore more? If this piqued your interest, you can always come hang out with us. Those of you in the room are in Grand Rapids, you can volunteer at Mary Free Bed. We love volunteers, especially college students. We have an entire spot on our website just for college student volunteers. The other thing you can do is you can be an adaptive sport volunteer. We always need help at events for adaptive sports. So that's a really cool space to be in if you ever want to hang out with people who do adaptive sports. And then the other two links are links to our national organizations through PM&R. So the AAPM&R has a ton of free available information about the field and has sections for both undergraduates and medical students. just to learn more about us. And then physiatry.org is another one that's even better. So as a wrap up, these are my kids that do activities based on rehab principles. So that's Calder Plaza. If you guys haven't seen it downtown, I'm sure you have. But they're gymnasts and trampoline artists. So after I'm here today, I'll be going to Novi tomorrow for a gymnastics meet and then a trampoline meet on Sunday. So, so thanks for your attention. I appreciate you guys. I'm gonna leave my kids up. Go ahead. That's a really good question. I'm going to repeat it because there's people online that can't hear you necessarily. So the question was about not realizing that I needed to sort of be motivational and sort of cheerleading for patients um, before I went into the field. And is there anything else that's kind of similar? And I think that, yeah, there is. And I think that kind of tails with that a little bit in that I didn't realize going into medicine, especially when not really growing up thinking that I was going to be a physician, um, how much I needed to maintain my own empathy in the face of taking care of people that really needed a lot of care. And so that I'm saying that because when you take care of people, no matter what kind of person you are, you could be a teacher or a doctor, or it's just somebody that takes care of people on a regular basis, you give your own empathy, you give something of yourself to take care of people. And I needed to pick a job that filled my cup back up after I gave that of myself. And I'm really like, when I look back on when I chose my specialty, I'm really, really proud of like my 22, 23-year-old self, because that's how old I was when I chose my specialty. And I didn't know that what I was picking would really do that. Where like seeing those patient successes and having patients that were really invested in their care and sort of like not following my directions, but were really engaged in their care was something that I needed. And I think I had a little bit of an inkling of that because I tended to be one that like in primary care spaces, I was frustrated when patients wouldn't follow through on things like taking medicines regularly. And so I think that's why I kind of shied away from that field, but now I can put words to it. And I really do think that whatever you guys pick for your career, pick something that fills your cup because that's really going to keep you in whatever you pick with some longevity and continue to be happy. And you'd spend so much time devoted to getting through medical school and training and things like that, that it's easy to burn out if you don't have that. Yeah. Go ahead, Mark. Yeah, so the question is, where do like psychologists and psychiatrists fit into a team of, I think, a person that's going through a relatively new injury or illness? And so they're an integral part of that team, especially in the short term, when you really do need to have discussion with folks about loss of function and about like realistic expectations for what their injury is going to warrant. So we employ psychologists at Mary Free Bed that are really specifically trained on helping patients to go through those feelings and get put words to those feelings and be able to talk to their family members about how they feel. And I think the physician and the psychologist as a tag team is a really nice team to be able to provide the patient with sufficient hope to say like, okay, these are the achievable goals and these are the ways that if you can't achieve a specific goal, how can we modify the approach to the goal to still be able to achieve it with as much independence as possible. And so the psychologist is there to sort of like recognize the fact that there's disappointment, but also shift the frame a little bit in terms of the approach to the problem so that the patient can like kind of grapple with that in multiple different ways. So that's like an initial hurdle. And then there's always the risk of like a long-term disability creating sort of chronic depression sort of issue. So having a person not only have that initial sort of psychology intervention, but also access to mental health um, resources, whether it be a counselor or a person in the community similar, or just regular check-ins with your physician. It's a normal part of our follow-ups in our clinic, just to check in on mental health and to make sure that we address it and respect it and approach sort of person from a holistic standpoint to make sure that we are engaging the right kind of resources when at the right time for folks. And you never know, like when I was a young resident, I used to think like, oh, if I had a really high spinal cord injury, that I don't know if I would want to live like that, or I don't know, I would probably be depressed. It would be really difficult. And there definitely are folks that go through that, and you witness that and you support them the way that they need to be supported. But there are also people that don't. There are people that are like, I'm so happy I'm alive. I get to do this life. I get to do these things despite this injury. And it's really interesting to see how individuals have perspective in different ways like that. So that's why I think it's important just to check in regularly to make sure that I, as a physician, am aware of what my patient needs, depending on them as an individual. Mhm. Yeah. 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 That's a good question. So the question's about practice environments for physiatrists. So are they mostly in city centers? Um, I would say just like any other specialist, they are like there's more concentration of them in city centers. But if you're a person that has this type of training and wants to live in a rural environment, you probably will be one of the most valuable doctors in the radius that you live in, because there just aren't enough of us to be in rural environments. There is a physiatry group in Marquette that has a clinic up in Houghton. And so there are people that do that, and they try every single thing they can to avoid having a patient in their practice get sent down to somewhere else. So would a patient do their acute rehab in that sort of situation, like right after they were injured? Probably not. But to be able to discharge a patient with a chronic injury or a chronic neurologic deficit into a community like that is like one of the best things ever, because they can get back to their home. Mhm. Yeah, we have a rural program at MSU within our medical school where we send students up into Marquette, and we have a couple other campuses that have rural certificate programs. And I had a couple of students. I actually have one that's graduated from the U of M PM&R program and went to go into the Midland Saginaw area that does rural medicine over there. And it's so fortunate when we have people that go into those communities. Mhm. Yeah.
Talked a bit about, in general, do you see it as a quality of life, trying to get them back doing things that they did pre-accident? Is it part of their therapy to, how does that all fit in? And is it usually trying to get somebody back into a sport that they were playing pre-accident, or is it more trying to find the right fit where they might?
Sure. Yeah, so the question is about like utilization of adaptive sports for post-injury recovery. It kind of depends on the person. It's one of those things where you kind of ask like each individual what they would prefer to do. I have a fair number of people who were hurt skiing, particularly with spinal cord injuries, who really want to get back to skiing, and they don't care how they're going to do it. They're going to get back to skiing. Like that seems to be the sport where like, if you got hurt skiing, you're still going to ski. And I'm like, okay, yes, please go skiing. Like that is such a cool thing to get back to. And there are lots of ways to ski. I don't know if anybody goes up to Cannonsburg and has seen the adaptive sports up there. That's a really, really cool program. There are a lot of people that get into adaptive sports who were never athletes before. And that's part of just exposure, where like a recreational therapist will say, well, we have all these things you could try. Do you want to try them and just see if you like them? And a lot of people do, because they feel like they can maintain some independence in that environment, and we can set them up with equipment that helps them access that type of activity. And we know, just based on research studies that have been done in that population, that access to adaptive sports actually improves risk of depression. So we encourage folks to consider doing adaptive sports, whatever that sport may be for them, because because it really does help with a lot of different things. So really kind of depends. But those skiers want to ski. That's I get it. Well, come hang out with us at Mary Free Bed anytime. And if you want to come to CHM, you'll see me there too.
All right, last chance. Any other questions? All right, well, let's thank Dr. Armstrong one more time. Want to thank our hosts, Aquinas College and Michigan State University College of Human Medicine, for putting on this event, and have a great night.